Practitioner Association of Sri Lanka. My name is Dr. Suriya. I am gastroenterologist and hepatologist from Bangkok Hospital, Thailand. First of all, I would like to thank you very much for inviting me here today and to have the opportunity to speak to you about the role of simethicone in functional dyspepsia. A topic outlined in the next 30 minutes, which includes the epidemiology, definition, diagnosis, pathophysiology, followed by the natural history and impact of disease. After that, I will summarize current algorithm and treatment options, as well as the benefits of using simethicone for functional dyspepsia. Start with, nowadays, chronic dyspeptic symptoms is still one of the most critical complaints and very challenges to many doctors or many physicians, because it could be originates from various organs such as stomach, duodenum, liver, gallbladder, and etc. Furthermore, the underlying pathophysiology ranges from benign to malignant disease. Therefore, prompt investigation include upper GI endoscopy should be done early in patients who has any one of the following alarm features, such as unintentional weight loss, odynophagia, progressive dysphagia, persistent vomiting, breathing, right, and unexplained anemia, for example, to exclude the organic disorder and to make a confident diagnosis of functional dyspepsia, right? On the other hand, for patients who have not or who have no any alarm features, what is a provisional diagnosis for this patient group? Okay, the literature shows there is a little chance of being cancer or significant pathologies in patients without any alarm features. So we are able to use functional dyspepsia as the initial diagnosis in this patient group, right? Let's move on and talk about the latest definition of functional dyspepsia in 2016. Bothersome postprandial fullness or early satiation at least 3 days a week, or epigastric pain or burning sensation at least once a week, but have impact on usual activities. Alright? And the above mentioned criteria must be fulfilled at least 3 months, the last 3 months, with symptom onset at least 6 months before, and there must be no evidence of organic, systemic, or metabolic disorder that's likely to explain the symptoms on routine investigation, including at the upper GI endoscopy. This is the latest definition. And we can classify FD into 2 main subtypes depending on the predominant symptom. The first is postprandial distress syndrome or PDS, and the second subtype is epigastric pain syndrome or EPS. However, in real clinical practice, a substantial number of FD patients have overlapping clinical symptoms between PDS and EPS subtype, right? Next, and what causes of FD? Today, the underlying pathophysiology of FD is probably multifactorial, involving a combination of dysregulation between the brain-gut axis, gastroduodenal hypersensitivity to hydrochloric acid, bile acid, or wall distension from food and gas, H. pylori-induced chronic mucosal inflammation, and as well as gastrointestinal motility disorder. Okay, and what is the natural history or prognosis of this condition? That's true. Functional dyspepsia has not been shown to increase the overall mortality, but long-term follow-up study indicated that just only 50% of cases achieve long-term disease remission, whereas 15% of them showed disease progression, and 35% has chronic fluctuating causes. Therefore, FD produce a much more negative impact on patients' quality of life compared to the general population. Okay? So, how do we deal with FD? This slide shows the beneficial current of therapeutic options in FD, which include: one is difference in drugs, dietary and lifestyle modifications, cognitive behavioral therapy, hypnotherapy, and acupuncture. However, actually, drug and dietary and lifestyle modifications are still being the first choice of treatment, and we decide to keep the rest as rescue options. Let's move on to see the current useful medications list for treating FD. The first is antibiotics for H. pylori infected cases. Next, anti-secretory agents, especially proton pump inhibitors or H2 receptor antagonists, prokinetic agents, antidepressant or anxiolytic agent, or some herbal medications, as well as antifoaming agents, particularly simethicone. Based on Asian consensus algorithm for FD treatment in 2012, the non-invasive test and treats for H. pylori infection was endorsed for patients who live in area with high prevalence. Then, proton pump inhibitors was suggested in epigastric pain syndrome, while prokinetic agent was recommended in those predominant PDA subtype, and a combination between PPI and prokinetic has been advocated in overlapping syndrome. After that, if symptoms still persist beyond week 8, antidepressant or anxiolytic or some herbal medication should be added. And finally, referral to specialists is mandatory for refractory cases. Alright? The benefits of PPI, prokinetic, or antidepressant was demonstrated by a current systematic review. The results of a meta-analysis in 2017 it showed that approximately 30% of cases will respond to PPI, with a risk reduction of remaining symptoms equals to 0.8, and representing a number needed to treat of 13. It means that you have to treat 13 functional dyspepsia or dyspeptic cases with PPI to improve one of functional dyspepsia. Alright? Yeah. And what is the efficacy of the available prokinetic agents such as cisapride, mosapride, etopride, domperidone L-methoclopramide? The data showed the overall efficacy of the above-mentioned prokinetic agents is also just 30%. So now we are waiting for a new emerging prokinetic agent, aconiamide, which has a higher efficacy than the previously agent. Mentioned to antidepressant. A meta-analysis in 2016 showed just only tricyclic antidepressant group, but not SSRI group, is beneficial for FD. with a risk ratio of 0.7 and a number needed to treat of 7. As mentioned above, you can see that a maximal efficacy of each drug group for treating FD is just only 40%. And as well as there is some limited data of using drug in a combination. Thus, other useful medication is now searching for. Let's move on. Let's talk about the simethicone for functional dyspepsia. Simethicone is a deforming agent. It decreases the surface tension of air bubbles that obscure mucosal visibility. Furthermore, simethicone also acts as a gastric mucosal protective agent. So, the current indication used for simethicone is for to enhance mucosal visibility or to relieve abdominal discomfort during the esophageal gastroduodenoscopy or EGD, as well as for FD treatment. The active ingredients of simethicone will not absorb through GI mucosa, so we can use this up to 900 mg per day with safety, right? This video will show you exactly why simethicone can improve mucosal visibility during the EGD. This is my dyspeptic patients who undergo the EGD. Now you can see that the tip of endoscope is passing through the second part of duodenum. At this point, you can find lots of air bubble found and obscure mucosal visibility. So water injection was trying to remove these bubbles, but failure. Thereafter, simethicone solution was used instead of water. Let's take a look. In just a few seconds, the obscuring foam and bubble disappeared. Surprisingly, okay? Yeah. As such, simethicone may attenuate gastric hyperdistension from stomach gas. Additionally, experimental data showed simethicone could be able to stimulate GI movement by accelerating transit of intestinal gas, as well as to prevent gastric injury from hydrochloric and bile salt. There are two well-designed studies to confirm the benefits of simethicone in functional dyspepsia. The first prospective randomized double-blind trial was conducted in 1999. 170 FD patients were randomized to receive simethicone tablet 84 mg twice a day, or the standard prokinetic supply 10 mg TID for 4 weeks. After that, the intensity of dyspeptic symptoms and efficacy of drug treatment was scored and judged by the patients. Let's see the results. At week 4 of treatment, the simethicone showed efficacy of simethicone was effective and comparable to the standard prokinetic supply, but interestingly, in the first 2 weeks of treatment, simethicone could significantly improve dyspeptic symptoms better than standard prokinetic supply. And if we talk about the patient's judgment regarding drug effectiveness, at week 4, the proportion of patient satisfaction in the level of very good efficacy is very higher in the simethicone group at 48% compared to just only 25% in the supply group. Yeah. Let's move. This is the second trial was conducted in the 2002 validation study by the same author, and 178 FD patients were randomized in a double-blind fashion to treated with simethicone 105 mg twice daily or cisaplide 10 mg twice daily, or a placebo for 8 weeks. The results show that at the end of the study, treatment with simethicone or cisaplide is better than the placebo, with significantly. Next, treatment with simethicone or cisaplide was effective as the same efficacy, right? In the first 2 weeks of treatment, again, simethicone is better than cisaplide significantly in the first 2 weeks of treatment. Based upon the patient judgment of treatment efficacy, you can see that at the end of the study, the proportion of patients whose satisfaction to drug effectiveness is very highest level in the simethicone group compared to the cisaplide or the placebo. Anyway, there are some adverse drug events occurs in all groups of treatments, but no statistically significant difference between the 3 groups, and majority of them experience just only minor and self-limiting side effects, except one patient developed serious cardiac arrhythmia while taking of cisaplide. So, from the main results of the above mentioned study, it's convinced that simethicone is effective as the previous standard prokinetic cisaplide. Simethicone is more effective than cisaplide in the first 2 weeks. As well, simethicone is no serious side effect as cisaplide. Therefore, simethicone was considered as a treatment option for treating functional dyspepsia by the American College of Gastroenterologists guideline in the year 2005. Finally, I would like to briefly summarize the main points of our tonight's talk. Firstly, functional dyspepsia is a common functional GI disorder which impacts to quality of life. Diagnosis is based on a combination of symptoms, good physical examination, and a negative EGD. Functional dyspepsia is acceptable as a provisional diagnosis in chronic dyspeptic patients without alarm features. PPI, prokinetic, or antidepressants have been the mainstay of drug therapy. Simethicone is beneficial and should be considered as a good treatment option. Dietary and lifestyle modification, reassurance, psychosupport are the key to successful treatment. And finally, prompt investigation should be done if symptoms still persist or develop alarm features. Thank you for your attention.
Excellent presentation. Now I'll keep the floor open for questions and clarifications. Cisaplide, as far as I know, is not available because now the arrhythmias has been deregistered, and we use a lot of domperidone now. Is it the comparison? Is it equivalent to domperidone or maybe equally? And another thing is we use a lot of PPIs in Sri Lanka. So your comparison with PPIs has not been there. Is there a possibility to?
If you find the literatures from the internet or from the articles, there is a little evidence about the domperidone, right? Because domperidone is not available in United States of America. So I try to find out the usefulness article about the domperidone is very little, so I cannot mention about the efficacy of domperidone. But in Thailand, it's also most of doctors, especially for public hospital, have to use domperidone instead of each other prokinetic agents. But for my hospital, my hospital is the private hospital, so there is no limitation to use. In general, for me, I use domperidone just only short periods because there is reported of serious cardiac arrhythmia from domperidone, and there is one case died. And the report is come out from the European country. So the black box warning in the European country, if you have to use domperidone, you have to use just only three times a day and not over or not more than 1 month for safety reasons. Yeah, and if for my experience to treat with patients with functional dyspepsia, I try to classify what is the predominant symptoms between pain, epigastric pain syndrome, or postprandial fullness, or sometimes there is overlapping in the real clinical symptoms, right? If the epigastric pain syndrome is predominantly, that's true, I use PPI, and if there is the fullness or flatulence or early satiation predominantly, I use prokinetic, but except domperidone for long term, and they understand, yeah. In the real life, prokinetic, available prokinetic, monocycline, etopride, if you see in the literatures, there are two diverse outcomes, and the meta-analysis about the benefits of monocycline or etopride, maybe some institutes show the benefits of monocycline, some institutes show the benefits of etopride, but in the real practice, depending on patient response, but you have to a little bit question or awareness when you use monocycline for long term, especially for patients who have underlying of cardiac arrhythmia. Understand me? That's right. Between PPI and prokinetic agents.
Now we have most of our antacid syrups, example like Gaviscon, have the antacid plus sevicol. So we tend to use that rather than pure sevicol. What is your idea on that?
Yeah. That a combination with those between.
And we have a combination of antacid. Most of the antacid which have aluminium hydroxide, magnesium trisilicate,
right. There are some evidence or some trial to confirm that combination with simethicone between simethicone or magnesium sulfate and activated charcoal is also beneficial, but there is just only 1 or 2 trials. Infections of combination between antifoaming agent and antacid tablet.
Functional dyspepsia, which is such a common problem in our practices, and I'm sure all of you will, everybody will get that, and we are also suffering from that very often. So I would like to also inform our membership that hopefully our next medical update program will be on the 30th of July, which is going to be an update on leprosy. So I will hope to see most of you all. Yeah. Today, unfortunately, because of the postal strike and the delay in the invitations going to each and every one of you all, most of you all have got it by email. But I think that's the advantage of having technology. So maybe the postal department also have to become I think, so that we not have these postal delays in the future. And also we are having a major problem now with garbage in Sri Lanka and also dengue. Yeah, Thailand is playing a very big part in management of dengue. I think dengue, they are the leading authorities on management of dengue, and they have taught a lot of our people how to manage dengue in Sri Lanka. So before any more comments, I would like to invite each and every one of you all for fellowship and on behalf of